That looks perfect. Thank you so much, everyone. Our last hour we'll be doing afternoon report with one of our PGY2s. If you haven't met him, Jose has a very interesting case today. Whenever you want to get started, Jose. I think you might just need, yeah, you're unmuted now.
Okay, hi. I'm Jose, I'm a second year. I would like to present a case for your afternoon report. 1 second. So this is a case of a 65-year-old female presenting with chest pain. A 65-year-old female with a past medical history of hypertension and breast cancer, status post-mastectomy and chemoradiation, presented with chest pain for 1 day. The pain started suddenly, is sharp and non-radiating. She denied fever, chills, nausea, vomiting, diarrhea, and also denied sick contacts or travel history.
Is there any, would you mind going back to that for everyone? What questions would you want to ask in relation to the chest pain to help kind of with your differential? If you want to post on the chat or unmute yourself, kind of things you would ask around the chest pain, like symptoms, or things you would ask the patient about their history. So some questions. So Sam saying, where is the chest pain? Is it reproducible, Jose?
So the chest pain is substernal. It's not reproducible to palpation.
Okay. Has she ever had it before?
It's a new onset. She's never had a similar pain before.
Is it there with exertion?
No, it's not exertional.
Non-exertional. And some questions asking how long ago her cancer history was. So when did she have the mastectomy and when did she have the chemoradiation?
Everything occurred in 7 years prior to presentation in 2014.
And Galit's asking, does the pain increase with cough?
Yes, the pain is worse with cough, and yeah, it is worse.
Any sweating or nausea?
No sweating and no nausea.
Sarah's asking, what was the patient doing when it started, and does she still have it now in the ED?
So she was just sitting down. She wasn't performing any physical activity. It started suddenly, and it was still present in the ED.
And I see Kavya asked if the pain improves with leaning forward. Why do you ask that question, Kavya?
I was just interested to see if the pain was like pleuritic, or interested in seeing if it resolves with moving forward, because pericarditis is on my differential.
So Jose, does it improve with leaning forward?
Yes, it does. It improves upon leaning forward.
Is it constant or is it coming and going? What's the other?
It's constant.
Perfect. And any other risk factors in the history you'd want to ask about? So this is a patient that has hypertension. When you hear of chest pain, what other things in the medical history are important to ask about or to know about? So Tony has said smoking, definitely. Does she have diabetes? So is she a smoker, Jose?
Yes, she is. She smokes half a pack per day.
And any diabetes?
No diabetes.
And then Omar is asking about any travel history. Why do you ask that, Omar?
If she was like in a recent long distance travel, like
a PE, yeah, definitely. So any recent travel, Jose?
No recent travel.
And asking as well, Galit's asking any history of MI?
No history of MI or coronary artery disease.
And any hyperlipidemia?
No hyperlipidemia.
Yeah, so I think you've hit on all of the main risk factors like hypertension, hyperlipidemia, diabetes, and smoking would be most concerning risk factors for this patient. And then Joe Amel's asking if she's any recent like viral symptoms or any URI symptoms.
So she complained of sore throat that started at the same time as her chest pain, but no other URI symptoms or viral symptoms.
Okay. So I think we've like a good bit of the story, the patient's chest pain. If you want to go ahead, Jose, and present the rest of her history.
So her past medical history is notable for breast cancer, as explained, with mastectomy, chemotherapy, and radiotherapy in 2014, hypertension, and fibromyalgia. She doesn't have any significant family history. She smokes half a pack per day. She denies alcohol or illicit drug use. No known drug allergies, and she's taking an anastrozole at home and amlodipine. On review of systems, it was positive for chest pain, headache, and sore throat, and was negative for fever, chills, shortness of breath, cough, diaphoresis, blurry vision, nausea, vomiting, and abdominal pain or GI symptoms or lower extremity swelling. So on exam, her blood pressure was 146/78. Her heart rate was normal at 78. She was also not tachypnic. She was afebrile and saturating well on room air. Her exam was practically unremarkable. The pain was not reproducible on palpation. Her lungs sounded clear, no wheezes, no rales, no rhonchi. Her heart sounded regular. There were no murmurs, no rubs, and no gallops, no JVD, no lower extremity edema.
So at this point, what would your assessment be for this patient? So if you were to put together like 1 or 2 lines summarizing what the patient's coming in with and a line that explains her exam findings, how would that be? Does anyone want to start that, or we can definitely do that together? So Venus, do you want to try?
Yeah, sure, I can try.
Yeah.
So, yep.
Do you want to go back, Jose, to maybe the history slide, and then we can show the physical slide just to help.
Yep, so she's a 65-year-old female with this past medical history of hypertension and breast cancer, status post mastectomy and chemoradiation in 2014, and significant smoking history, presented with the chief complaints of chest pain, non-radiating, constant, and sharp for 1 day.
And how would you, if you were to use like a medical terminology to describe her chest pain? So it seemed to be there with coughing.
Yes.
What kind of chest pain?
Pleuritic.
Exactly. So we could summarize this and call it like a 1-day history of pleuritic chest pain.
Yeah.
And Jose, do you want to skip ahead to the exam? I guess, Venus, what do you notice on the, or I guess what do you not notice on the vitals physical exam findings for her?
Vital seems pretty stable as of now.
Yeah.
The blood pressure is a little bit towards the higher side, but not. It's just the systolic, and no pertinent findings on the physical examination.
Exactly, that's excellent. So it's kind of highlighting her risk factors, obviously this hypertension history, smoking history when we're thinking of CAD, and also this breast cancer history, right? A malignancy history, and also this radiation history, and noting that it's pleuritic chest pain. If we were to kind of summarize all of the words that we had put together for her chest pain, pleuritic chest pain, and the fact that her vitals are all pretty normal, right? She's not hypoxic, she's not tachycardic, and her lungs sound clear. So calling that all then like unremarkable physical exam. So with that, I'll probably start sharing my screen if that's okay, Jose.
Yeah.
So we started off by saying that this patient has pleuritic chest pain. which is chest pain that the patient feels with breathing. So with inspiration, expiration, patients feeling chest pain. What kind of differentials come to mind when you think of pleuritic chest pain, or what are things that you need to think of? You can post it in the chat or unmute yourself, but what would your thought process be, or things that you need to think of? So Kavya is saying pericarditis and PE. So the PE, I guess, for sure for her would be very concerning given her malignancy history. I guess, Kavya, what kind of things would you expect to see on a physical exam, maybe for someone with a PE?
So for PE, you would usually see a patient who's tachycardic, typically in sinus tachycardia. They typically are dyspneic, and there could also be evidence of like a DVT. So you could see unilateral lower extremity swelling and tenderness, warmth.
Exactly, that's excellent. So sinus tachycardia would definitely be something to look out for. I guess hypoxia sometimes, depending on the severity, but I think for a patient like this, definitely looking for a DVT, because if you've like unilateral lower extremity swelling, and that could make it much higher on your differential then. And I see Patricia said pneumonia. For pneumonia, Patricia, what other things would you expect to see, like on a history physical, that will point towards a pneumonia?
I guess that the patient would also have like fever, could have tachycardic, could be dyspneic or tachypneic as well.
And on the lung exam?
And the lungs exam, you would find like crackles.
Exactly, yeah, you might expect like fever, short of breath, but you might expect to see something on lung exam depending on the severity of it. And I see Samantha has mentioned pneumothorax as well, and would definitely be something very important to consider early on in the patient's course. I guess, Samantha, what would you expect to see on examination for a patient with a pneumothorax?
I guess they would be more hypoxic than he would be, and they would have decreased lung sounds on the side where the collapsed lung is.
Yeah, and they would be hyperresonant as well. So when you complete your lung exam, you might note hyperresonance as well. For pericarditis, I see Samantha Rubin and Kavya mentioned that as well. I know, Kavya, you had said that you would expect like when it's leaning forward, so if you have inflammation of the pericardium, when the patient leans forward, it should improve, and when they're lying back, pain can be worse for them in those instances as well. And the other thing Tom had mentioned, dissection, would be hugely important. What other things would you see on history physical, Tom, if you had a dissection?
Maybe some pain reading more towards the back. They'd probably be pretty hypertensive. They'd probably look a lot sicker than this person is.
Exactly. And I think that's key here, that this patient, at least her vitals, her exam, she looks relatively comfortable. A dissection, you look for like maybe asymmetrical like blood pressure, checking on both sides, and a much more abrupt onset. And I guess with a couple of these symptom or a couple of these diagnoses, you expect maybe more an abrupt onset of symptoms, right? If you have a dissection in pneumothorax, they're probably going to be coming into you sooner than like a day. And this patient's had symptoms for about a day before they've come in. And radiating to the back would definitely be part of that too. And then checking blood pressure for that. And I guess the other thing to be mindful of, even though it wouldn't be like the typical way, but ruling out an MI would be hugely important. This is an elderly lady, likely postmenopausal, with a hypertensive history. And so even though we don't normally expect MI to present as pleuritic chest pain, it's definitely something that you would need to consider based on the patient's risk factors for sure. And I guess more related to the lung, any other conditions in the lung? So we've said pneumonia, pneumothorax. There's, I guess, one other thing to think of in the lung causing pleuritic chest pain. it also begins with pleural. So pleurisy, yeah, or pleural effusion. So any like inflammation that you might have, or pleural effusion, anything there that's going to be irritating. So that can be like infectious if it's like a pneumonia. It can be like malignancy related. So that could be hugely concerning in this patient that we have. Is this like the first sign of like a recurrence of her cancer that we're seeing? Either like, you know, some sort of pleural effusion, pericardial effusion, and I guess other things might be autoimmune, but in this patient, she's older with no like autoimmune history, seems less likely. So with this patient coming into the emergency department, what would be either labs or imaging? What things would you want to check first, and why? So again, you can post on the chat. Okay, so I think Neha had her answer ready to go. So EKG for sure. We talked about ruling out MI, and also will help you with other things as well. Pericarditis, you can have EKG findings on PE. You might see things like right heart strain. Troponin will help as well, especially for ACS. Chest x-ray. So I guess, Debbie, for chest x-ray, what kind of things would you be looking for on a chest x-ray, or how would it help?
So for chest x-ray, we can visualize any consolidation to rule out pneumonia. Also, we can check if a patient has a collapsed lung to check for pneumothorax, or if the patient has blunting of the costophrenic angle to show if it has pleural effusion.
Exactly, that's excellent, and it will help you rule out or rule in a lot of these. I guess, and the other thing it can help with, if you have a dissection or you're concerned about that, and maybe a lower risk patient, you might expect to see widening of the mediastinum, could also help with that. And Kavya said bedside POCUS. What are you going to do on the bedside POCUS, or what will you see?
I would examine the heart to see if there's evidence of like right ventricular strain. I think there's like a D sign that occurs in PE, and yeah.
And you can also use your POCUS as well, and depending on who you're doing it with, it can help you look at the lungs, right? So it's really useful for ruling out, or really sensitive for ruling out like a pneumothorax, and helping to identify and quantify like a pleural effusion. So it can help with lung as well. And then CTA, Neha said, what would the CTA help you with, or when would you order that?
It'll help us rule out PE.
Exactly, and especially if you have a high suspicion of PE, or if you had a high suspicion of dissection. I think that's something definitely worth doing, but we would probably, the most reasonable place to start would probably be with the EKG, chest x-ray, troponin, and probably like other basic labs as well. So if you want to go ahead, Jose, and you can share your screen and kind of talk us through what workup was done and what it showed for this patient.
Right. One sec. Am I sharing? Okay. I think. So we went through this with Jackie, the differential. So these were the labs that were ordered initially. They were remarkable for a creatinine of 1.81. There was also an elevated CRP of 86.5 and an ESR of 39. Otherwise, the rest of the labs were unremarkable, with a negative troponin. BMP was 149. Sodium and potassium were normal, and no elevated white count. And this was her EKG.
So I guess this patient had quite an interesting EKG. Does anyone want to start and maybe start looking, maybe we can look at the rate and rhythm together. What would the rate be on this EKG?
Can I just ask a quick question?
Yes.
What was the reasoning behind doing the SID rate and CRP?
So she suspecting pericarditis to assess whether there's any inflammation or a degree of inflammation or myocarditis as well, suspecting those differentials.
Oh, okay. Are they usually useful for the cardiologist to figure out if they have myocarditis or?
So they maybe not for initial diagnostic purposes, but they are useful to assess the degree of severity or degree of
okay.
Also a little somewhat for diagnostic purposes as well. Maybe they may not be the main method to diagnose these pathologies, which are often clinically diagnosed, but they can make us think more towards one thing, I guess, than another.
Okay, I would just be careful because in an elderly female, they're going to be elevated. So they can also send you down wrong paths, right? So anyway, okay, go to the EKG.
So does anyone want to comment on what the rate was?
I could give it a try.
Yes.
In the EKG, it looks like it's in sinus rhythm because every P wave is preceded. Every QRS is followed by a P wave, and every P wave has a preceding, a following QRS. The rate is approximately 60 beats per minute.
Yep.
And there is diffuse, there's ST elevation in lead 1, 2, 3, AVF, like possibly like diffuse ST elevation with also.
What other leads are you seeing ST elevation?
I'm sorry?
What other, so I know you said 1, 2, 3 in AVF, you see ST elevation, do you see it on other leads?
I do see it on lead V3, also on V4, V5,
Yeah.
diffuse
yeah.
ST elevation.
For sure. So it's kind of extending across like all different regions, right? It's like the inferior leads. We have it in some of the anterior and some of the lateral leads. And it doesn't seem like there's any like reciprocal ST depression that you would kind of expect if maybe there's an MI or something like that. And the other thing that was kind of interesting in this EKG is you do have, if you look at the leads where you have like your ST elevation, like especially in lead 2, you can see pretty pronounced PR depression in those leads too. And so along with this like very diffuse ST elevation, you have this PR depression along with that as well. So does anyone know or want to say what this EKG would be most compatible with?
Pericarditis.
Pericarditis, yeah. I think Kavya said that diagnosis within the first couple of minutes of this presentation, actually. So if you want to go ahead, Jose, and present the remaining data.
All right. She also got an X-ray. Would anyone want to say like what they see, or should I just go ahead? It's
yeah, if anyone wants to say, if you just see any abnormalities or anything that you notice in this patient, I think there's like 2 things that you can say you definitely don't see in every chest X-ray. So on the right side, so I guess in the ICU, they'll always ask about lines and things like this. So this patient has a line. So Joel Mel, yeah, it looks like she has maybe a right porticath on the right side. And can anyone tell which side her breast cancer was, maybe from this chest X-ray? So left, so Omar's saying left, yeah. So it looks like maybe she has a prosthesis there. I'm not sure, but you can see the kind of surrounding tissue from that. But I think they're the main things, otherwise her chest X-ray no obvious abnormalities, and the things that we've said, looking for like a pneumonia, pneumothorax, and we don't really see any of those here. So you can go ahead, Jose, if there was any more.
Oh, so there was also a TTE that was practically normal with an ejection fraction of 55%, and except for some pericardial thickening, but without any pericardial effusion. So she underwent further investigations, underwent autoimmune serologies. She had a positive ANA, and then had a couple of other labs that were all negative for autoimmune pathologies. So the final diagnosis would be acute idiopathic pericarditis. So in summary, pericarditis involves inflammation of the pericardial sac. It has many possible etiologies, including autoimmune, uremic, neoplastic, TB, bacterial, or purulent, but most of the cases will be viral or idiopathic, where really no particular cause is identified. So the most typical presentation is chest pain, and the characteristics of the chest pain are important. Tends to be sharp, pleuritic, meaning that it gets worse with inspiration or with cough. And also it relieves when sitting upwards or leaning forward, because this position reduces tension in the parietal pericardium. And sometimes it can also radiate to the trapezius ridge. On exam, the most characteristic finding, which isn't always present, but it's pericardial friction rub, consists of creaking or scratching with systole or diastole. Can sometimes sound similar to a murmur, but it is present throughout the cardiac cycle. So I'm gonna share a sound clip. One sec. Am I sharing? Okay, so this is how friction rub sounds like. Perhaps the most characteristic finding of pericarditis is the EKG with widespread ST elevations, can actually have reciprocal ST depression in AVR and V1. Actually, this patient had a depression in AVR, which is a lead you usually don't use to assess for distribution of coronary arteries, and also importantly, the morphology of the ST elevation is a concave elevation compared to STEMIs that can tend to have a more convex elevation, like a dome-shaped elevation, but not always the case, but it's usually what tends to happen. And also PR depressions that tend to be more pronounced in V5 and V6. With PR elevations in lead AVR. And this is also not always present, so it's not very sensitive, but it is highly specific. Sometimes it might be important to differentiate the EKG in pericarditis with one in ACS. Actually, for this patient, she was still in the ED, had already been diagnosed with pericarditis, and the EKG I showed you, but then had a repeat EKG, and then showing the same findings, and the nurse called a STEMI code, and then she was transferred to resus, and then they immediately realized she was actually having pericarditis and not ACS. So the EKG can be a bit scary at first, but it's different from ACS in the fact that ST elevations are widespread and not limited to anatomical groupings. Also, as I explained, the morphology of the ST elevations tend to be more concave. There's also rarely any reciprocal changes, except in leads AVR or V1. There's also rarely any concurrent ST and T wave changes, like at the same time, which in ACS can be seen. And also, you do see the PR depressions, which are rarely seen in STEMI. And also, there's rarely any new pathologic Q waves or hyperacute T waves that are characteristic of STEMI. So other tests, the TTE is often normal, but sometimes pericarditis can be associated with an effusion, which can be seen on TTE. Chest X-ray is often normal unless there's a large pericardial effusion that enlarges the cardiac silhouette. Troponin can also be elevated in around 32% of the cases, which wasn't the case for our patient, but should make you suspect myopericarditis. Also cardiac MRI and CT are tests that can detect inflammation and pericardial thickening and effusion, which would be a second or more confirmatory exam for pericarditis. So the treatment, so the first line treatment is NSAIDs and colchicine, because since most cases are idiopathic and viral, this is the first line therapy. So the only caveat is that colchicine theoretically can worsen outcomes if it's bacterial pericarditis, which is usually 1% of the cases, but there's really no data. It's just theoretically theory, but not really, there's really no data supporting it. So the duration of NSAIDs is usually 2 to 4 weeks, but this can depend based on symptomatic response. And also for an initial episode, colchicine is usually given for 3 months. Another option is steroids, which are not first line, but can be used if symptoms are refractory. And if the pericarditis is associated with a large pericardial effusion, there can be, you might need a pericardial drainage or pericardiectomy. So it is important to follow up these patients since in many, the pericarditis can recur, and in 1%, they can develop constrictive pericarditis. Sometimes the cardiologist might want to do an echo a few months after an episode of pericarditis, make sure that this hasn't happened. So thank you. And any questions?
Yeah, I guess the only thing I would add regarding the NSAIDs is you can use aspirin to treat it, but it's a much higher dose than I guess we're used to seeing that we give for other conditions. So I think it's like 650 milligrams or even up to 1 gram you give several times a day when you're giving aspirin to treat it. But thank you, Jose, for a really good case. If anyone has any questions or comments, you can post in the chat or unmute yourselves.
Do we know how she did?
Sorry?
Do we know how she did? Was there any follow-up after she left?
So her pain was persistent throughout the hospitalization. It slightly improved, but I unfortunately could not follow her until her discharge. It was on a Saturday, but she felt, I know she felt better than when she came in, and according to the notes, her pain did resolve eventually when she followed as outpatient, and she was continued on NSAIDs and colchicine. But I would say she did well without any complications.
I have just a quick question. I know you said it was, idiopathic, and it's hard to sometimes find a cause for these, but, she was status post radiation, and I know like radiation-induced, pericarditis is a thing, happens short-term or long-term, and this is on, she had left-sided breast cancer. Any consideration to that, or I guess it's just too hard to prove?
So yes, I think you said it right. It's a little hard to prove since radiation occurred many months ago, and the most common cause is viral or idiopathic. Sometimes if the patients have a pleural, like a pericardial effusion with a history of cancer, maybe if you tap the fluid and analyze it, that would be helpful in diagnosing the etiology. But it wasn't the case, and it wouldn't, the management of the pericarditis itself wouldn't change that much if that were the case.
Yeah, but I guess the only thing then is, to Tom's point, maybe would that mean that it's potentially more likely if it is radiation induced, could the patient be more at risk for like a constrictive pericarditis later, even like after you're treating them, which I guess would be a possibility for sure if you don't know, you know, if it was her sore throat or some viral illness versus if this was radiation induced, could there be concerns for developing constrictive pericarditis later? Well, I think if there's no other questions or comments, we can leave it there for today. But thank you so much, Jose, for a great case.